talked about the RAE. I've been working on the RAE for a long time. Even before working at RAE, I worked at the state on the Accountable Care Collaborative. So it's really exciting to be presenting to you today. We're going to cover some of the just basic nuts and bolts. What are the responsibilities of the RAE? What are the key performance indicators? There have been some changes in enrollment and attribution that I know a lot of people have questions about. Why is RMHP a RAE? What does our governance structure look like? What is the PRIME program, network management, care coordination, and population health? And then, of course, always happy to have discussion or talk about any other topics that you all think would be helpful. So what is the RAE? So the Accountable Care Collaborative was Colorado Medicaid's attempt to manage costs and improve quality. So before the Accountable Care Collaborative, which was implemented in 2011, Medicaid enrollees were just in fee-for-service, and there was no system to help them connect to the care that they required. So if someone needed something, there wasn't any sort of care coordinator or plan entity. And so the Accountable Care Collaborative was implemented in 2011, and it was next to the behavioral health organization. So there were 7 regional care collaborative organizations and 5 behavioral health organizations. The regional accountable entity, and so that was implemented in 2011, starting this July, so July 2018, the regional accountable entity merges the behavioral health organizations with the regional care collaborative organizations, and there are 7 RAEs. However, the regions are slightly different than the. I'm getting echoing. If you're not talking, if you could mute, that would be great. And Christina, don't hesitate to tell me if I need to slow down or if I'm not clear. So, the RICOs and the BHOs merged to become RAEs. There are 7 RAEs. The regions are slightly different, although Region 1 is the same. The overall goal of the RAEs is to improve the health of members served by Health First Colorado, which is Colorado's Medicaid program, reduce costs, address physical, behavioral, and social determinants of health, and move towards value-based payment. The contract is a 7-year contract, so we will be the RAE in Region 1 through June 2025, according to our contract with the state. So the core responsibilities of RAE are a few. So one is we're responsible for that behavioral health capitation. So, you know, as I just mentioned, there was sort of this separate behavioral health system from a physical health system. The behavioral health system is capitated, meaning that the state pays previously the BHOs and now us, the RAE, a per member per month, so a fixed amount per member, and we are responsible for reimbursing behavioral health providers and managing all of those costs within our fixed amount. The physical health system still is fee for service. So we receive a per member per month payment to support care coordination and provider support and all of the other activities we do. But that comes out of that per member per month. We're not capitated for the whole region for physical health. So we're responsible for administering that capitation and contracting and credentialing and paying behavioral health providers. We're responsible for ensuring that there's a network of providers both within the behavioral health system and the physical health system that will serve Medicaid enrollees in our region. We're responsible for supporting providers. And then some of the new requirements around population health. We're required to have a population health plan that really looks at the needs of all of our members and addresses not only acute needs, but prevention and upstream interventions. Also a new requirement is the health neighborhood and community engagement components. So in the RAE, the department articulated a vision around having a health neighborhood, which encompasses all of the health providers that serve a particular member, and then a broader community that includes all of the various types of organizations, including human services, nonprofit organizations, and other organizations that serve a member. And in the request for proposals, the department articulated a responsibility of the RAE to engage that broader community. That's part of why I'm so excited you all asked us to talk with you today, because this is exactly what we want to be and should be doing. We're responsible for engaging our members directly, so we do a number of direct-to-member interventions and care coordination and other activities. And then, of course, we're responsible for ensuring that members have care coordination to the extent that that would be helpful for that member. So this is the map of
you want to check if
yeah.
there's any questions about those services? Anybody in the group have particular questions about what Catherine just shared around the services?
And I will talk about some of them in more detail.
Okay. Okay.
Happy to take questions too.
Yep.
Thank you for stopping me, Christina. You should keep doing that. And I get on a roll and I just keep talking. So this is the map. So this is the blue on the left is obviously the region that you all are in and that we are responsible for. There's really, there's Colorado Access has 2 regions. Colorado Community Health Alliance has 2 regions, and then these regions are separate organizations. So there's actually not that many organizations overall. So these are the key performance indicators. So these are really important. They are tied to incentive dollars. They're predominantly based on improvement over baseline. And if we succeed in making, most of them it's 5%. I won't go into the details of each calculation, but most of them it's roughly a 5% increase. If we succeed in improving by 5%, we as the RAE stand to earn almost $8 million. We're really committed to reinvesting those funds in our communities and in our efforts that really improve member care. And so we would love your engagement and assistance in trying to tackle some of these things that we know are so critical for member health. So I have to say, when I looked at these, when the state released the list, I was really excited because I feel like a lot of these are preventative. They are really the things that we should be focusing on. So the key performance indicators are dental visits. So everyone in Medicaid should get an annual dental visit. Well visits, once again, everyone in Medicaid, the goal is to get everyone in Medicaid to get an annual visit. Prenatal care, behavioral health penetration rate, which is just the percent of people who received any sort of behavioral health service. Historically, in Colorado Medicaid, the number of people who've received behavioral health services is lower than what we would expect, knowing what we know about incidence of behavioral health conditions. Are you guys getting feedback? I'm getting a little funny noise.
Yeah, hi everybody. Okay. Go ahead and hit your mute button if you're not asking a question, and then unmute if you want to ask a question.
I don't know how to mute on. No, it doesn't give me on the computer, it's on your bottom left. So if you scroll your mouse over the bar at the bottom, there's a little microphone to the left that you should see. I have to tell you though, as I said that, I tried to do it and I can't find the little microphone button, but theoretically it's there.
Yeah, so are you on the computer, Nan?
No, I have the phone on and the computer, but I'll hang out. I'll just call in separately, I guess, again. Keep going.
Okay, I'm sorry. So potentially avoidable costs. So that's really trying to avoid those things that that are potentially avoidable. So an example of a potentially avoidable cost would be an ER visit for asthma. We know that people who have well-managed asthma don't actually end up having to go to the ER. The same is true for many chronic conditions like diabetes. ER visits is a measure in and of itself. And then the final measure is a health neighborhood measure. This is a combination of 2 things. So one is we are working on creating care compacts between primary care and specialty providers. The goal of the care compact is really to articulate how you're going to share one patient. So when a patient gets referred from primary care to a specialist, what information is what information is the primary care provider going to send to the specialist, and what information can the primary care provider expect back? And what's the process for deciding who manages the condition? So with many conditions, a special consult is only necessary once, and then the primary care provider can work with the patient on the plan that the specialist has come up with. And so the goal of that compact is really to articulate all of those things about how you partner around the care of one patient. The other piece to the health neighborhood measure is we are working to have, when a patient gets referred to specialty care, we want to make sure that they went into primary care first. And so when they go to specialty care, they should arrive at specialty care with the billing ID, and the patient themselves doesn't have to carry this, but our goal is to have specialists have communicated with primary care providers in advance of seeing Medicaid enrollees and actually put the billing ID of the referring primary care provider on the claim. So the goal is really to make sure that primary care is the first line of defense, and they're the ones identifying when a patient requires specialty care, and that they're coordinating so that tests don't have to be redone. Basic, history and other information is sent in advance of the patient visit, so that the system is as efficient for the patient as possible.
Okay, hey Catherine, we got a question from the Zoom chat. So Kristen, Kristen, can you tell me who this is for sure? All I'm seeing is the first name, so I just want to make sure I'm talking to know who I'm talking to.
Kristen Baronsky.
Okay, hi Kristen. Yeah,
hi.
So that's, if you're asking if there's only one dental provider that takes Medicaid in the Valley, that's actually not correct. There are quite a few through Mountain Family. There's also Comfort Dental, and there's All Kids. And in addition, when the Basalt Mountain Family Clinic comes online, there's actually going to be even more Medicaid providers. So I can talk with you more about that, and we can talk about So because I definitely wanted to share that, but I know one of the challenges we have with dental is the fact that there is not a dental provider in Pitkin County. And so
right. Well, thank you for that, because we really have struggled to get coverage for people.
Yeah. So definitely can get you information of who does take Medicaid for your patients, and so I'll be happy to do that.
Yeah, and I was going to mention this later, but maybe it's worth mentioning now. So dental care is sort of strange. It's not under our umbrella. There's a separate vendor, DentaQuest, who's responsible for dental care. We are just incentivized to make sure that people are getting into dental care, but we don't contract with or pay or otherwise manage the dental network. That said, I'm actually meeting with DentaQuest in a week or two, and I'm happy to share concerns. I know that they're really motivated to try to get patients in, and they're really motivated to work on some of these things. So I'm sure they'd love to speak with you, this group of people themselves, and I'm happy to help make that connection. Great. Anything else, Christina?
That's all I've gotten so far. Any other questions before we continue? Okay, I'm going to keep going. So we have a second set of measures. It's also really critical. Christine, I'm going to assume you're looking at the chat because I'm not good at doing both. So the second set of measures is really the behavioral health incentive measures. And I'm just going to touch on a few of these. Some of these are sort of administrative measures that I don't think are worth mentioning to you. But the ones that I really want to focus on are follow-up within 7 days of a hospital discharge for a mental health condition. So we're really trying to make sure that patients who are hospitalized for a mental health condition are seen, preferably back in the mental health center, wherever they've been seen before, within 7 days. Engagement in outpatient SUD treatment, so for patients who screen positive for an SUD need in an assessment, we want to make sure that they're actually getting in for substance use treatment. We want to make sure that every patient who is in foster care receives a behavioral health screening or assessment. So we're really trying to increase the number of foster care children who have a behavioral health screening or assessment. We are responsible for making sure that there's follow-up within 7 days of ER visits for substance use disorders. And then finally, we are responsible for making sure we have follow-up after a positive depression screen in primary care. Hey, Catherine, another chat question we had before we move to the next pace. And so our population, so the question comes from Nan. So the population in Pitkin is underutilizing healthcare. How will you communicate with your key performance indicators with consumers?
So, I mean, I don't know that consumers care what our key performance indicators are, but we are trying to communicate. I mean, these are the right things, right? We want to get people into preventative care. And so we are trying to communicate in a variety of ways, but honestly, that's partially where we could use you. You know, we only have so many touch points with our provider or our members. We can send mail, we can call them. But then at the end of the day, we kind of need other people to help us who have more face-to-face interaction with members who can say, oh, you should really get an annual well visit, or have you thought about getting your annual dental visit? So we are trying. It's in a lot of our communications. We've built it into almost everything we do that touches members, but it's definitely a work in progress. Does that answer the question? Any other follow-up questions?
Nan, does that answer your question, at least as a starting point?
Can you hear me?
Yes.
Oh, how fun is that? No, thank you. I think that the consumer literacy of benefits, as well, the importance of a neighborhood, a primary care home, preventative checks, that feels like a big gap in understanding. So we can talk about that later or in our county meeting, but somehow we need to help people understand that going to the doctor, having an annual, being proactive is a good thing.
Yeah, I think that would be great. I would love to have that discussion. We definitely could use help thinking through the best way to do that.
Thanks.
So I just wanted to make a few notes about enrollment and activation. I don't know if this is too in the weeds, if this is something you're tracking on, but there have been some pretty significant changes since July in terms of how members are enrolled and how they're attributed, which means how they're connected to a primary care provider. So the first is that in the last version of the ACC program, there was a process called passive enrollment, which we used to jokingly call passive aggressive enrollment, because we would send a letter to Medicaid enrollees saying you are going to be enrolled, and then if they didn't respond, they were enrolled. But that whole process took 2 to 3 months. Very few people opted out. So in this version of the Medicaid program under the RAE, enrollment is mandatory. So when patients become enrolled in Medicaid, they immediately get enrolled in RAE. So we immediately, know that they're on Medicaid, so we can help orient them to Medicaid. One of the challenges with the old system was that there was a big gap where they weren't our responsibility, and so we weren't able to orient them, in that critical period of time where they were just getting on their benefits. And many of them had shorter periods of time that they were even on Medicaid. And so that sort of cut into the amount of time we had to really help them get those services that they required. So, under the current system, they'll be enrolled immediately. Enrollment also begins on the eligibility date. So it's not just the first day of the month. It used to be only on the first day of the month. So that's part of that mandatory enrollment process. Enrollment is based on where their PCMP is. So the state really wanted to connect the location, the PCMPs to the RAE. And so that's been making sure that all the members that are associated with PCMP came with that PCMP, as that PCMP worked with one RAE on their health services. And so that's sort of changed who ends up being enrolled where. I think in your region, you're not a border region, so it shouldn't be a big issue for you, but for some of the regions, that's caused some people to move from one region to another. In addition, members are immediately attributed to a PCMP. So they're either attributed based on their history, so if they've gone somewhere, then they'll be attributed to the provider they've already seen. If they have not gone somewhere, then they will be automatically attributed. The state will look at the attribution, so which patient was connected to which provider, every 6 months, and move people. If, for example, if you're attributed to your provider, you're actually seeing a different provider, you'll be reattributed to the provider you're actually seeing on a every 6 month basis. So that might be a little bit in the weeds, but thought it was important to mention. So why is RAE a RAE? So we've had a 44-year commitment to serving Medicaid beneficiaries. We were really motivated when we applied to have the support of our community partners, especially the federally qualified health centers and the community health centers. And they actually signed on to support our bid under an umbrella that they call Reunion Health. And I'll talk about that a little bit more when I talk about our governance. We also have a really exciting partner with a national healthcare payer, United Healthcare. So as you know, we became a part of the United Healthcare system, gosh, like a year ago. We're still in the process of transitioning, but it's really exciting to be part of United Healthcare. You know, United has, I think, 26 Medicaid plans across the country, and they have a lot of expertise and resources and ability to effectively serve Medicaid enrollees, while being committed to allowing us to have the local flexibility and leadership to continue to run the Rocky Mountain Health Plan. Also, I know there was a specific question about the Rocky Mountain Foundation. So when Rocky became a part of United, because we were a nonprofit becoming a for-profit, any of our assets got converted into a health foundation. So I believe it's called the Rocky Mountain Foundation. Hopefully I got that right. And they are in the process of grant making. I think they've already made one round of grants, and we are not affiliated with them. So they're an entirely separate legal entity. It's actually legally required that they be unbiased and be able to operate separately. So I'm happy to connect you all with them if you're interested. But they're, as far as I know, up and running. So our key principles for the RAE, and actually for Rocky, I would say, are being member-centric and whole person-oriented, supporting integrated care, not just physical and behavioral health, but also social determinants of health, having a broad and inclusive network that allows members choice, supporting community partnerships, and really allowing one-stop shopping. So really figuring out how patients can come in through a variety of doors and get all of their needs met as efficiently as possible. So we are really committed to making sure that the running of the RAE is in partnership with all of you, with all of our community partners. So we are in the process of sort of trying to build our community governance structure. So I mentioned Reunion Health. So Reunion Health is a legal entity formed by a set of FQHCs and CMHCs in the region who helped us with the bid. They provide us with a significant advisory process. Within, as part of that, we have a directors committee that will include, a variety of community partners, potentially including some of you on this call if you're interested. So we are working on, so we haven't, just to be clear, we have not put these in place yet, except for the Member and Family Advisory Council. We do have a Member Advisory Council, but we would like to have a Community Leadership Council, Primary Care Medical Provider Council, a Behavioral Health Independent Provider Council, and a Hospital and Specialty Care Transformation Council. And then we are required by the contract to have this broad Performance Improvement Advisory Committee that will sort of help connect the dots between the Directors Committee and other community priorities. So we're still working on this, fleshing this out. We have our first PIAC on November 2nd, actually in Summit County. I think it's in Frisco. I might have made that up. It's somewhere there. It's either Silverthorne or Frisco. I forget. Would love to have anyone on this call who wants to attend to participate. So Christina has that information and can send it out. We'll get a formal invite out. It is November 2nd, I believe from like 10 to noon or 1 or something like that. So it's the sort of middle of the day on November 2nd, and would really love to have you all there. And we'll talk more about this governance process and solicit your input, and also solicit people who would like to help us participate on any of these committees.
Catherine,
what's
the timeline on some of the others getting formed, and like what are you guys, and how is that going to work, or do you know yet?
Yeah, I don't think I know yet. So I know Member and Family Advisory Council is already running. It's something we had under the RICO. We've just continued running it.
Okay.
We will be, the PIAC, that November 2nd is the first meeting, and I think the attendees of the PIAC will be soliciting participants for these other councils. And thinking about the connection between the Directors Committee. The Reunion Health Partners will largely be in attendance on November 2nd. And so we're really hoping to flesh some of this out then. So I'm sorry, I don't have a great answer.
Okay, so a couple questions about that. So Nan asked, how's community defined? Should we participate in the Summit County PIAC, or will there be others?
Yeah, so that is the PX for the whole region. So it is our Region 1 Program Improvement Advisory Council. So there will not be, for this particular kind of forum, we definitely want to have multiple ways for you to engage at a local level. We're also happy to come to you like I am today. But this particular meeting is intended for the whole region. So if you are able to attend or send staff to attend, I would encourage you to do that. It is an opportunity for you to influence how we think about how we organize and solicit input and provide and have this governance structure.
Okay, great. And then another question, what organizations currently are making up the Directors Committee? And then with that PACT meeting, will it also be a webinar?
I believe we will have a call-in option for the PAC.
Okay.
I will work on getting you all that information. The Directors Committee is not seated. The goal is to have representatives from all of the councils as well on that Directors Committee. So, yeah.
So that's still forthcoming.
That's all forthcoming.
Okay. That's all that's all I see for now.
Okay. Okay, so I wanted to mention Prime. So I've just finished explaining to you how physical health is fee for service and behavioral health is capitated. So now just to make it more confusing, in a small section of Rockies region, we have a special program. And I say it's special because most of the other RAEs don't have a program like this. But we have a small managed care plan where we receive a capitation for physical health services. So that program is called Prime. It was authorized by House Bill 1281 in 2012. Yeah, so 1281. And it covers Rio Blanco, Garfield, Pitkin, Mesa, Delta, Jefferson, and Montrose. And it's really for adults and children with complex needs. So it's not even all enrollees. So most healthy children are probably not in a Prime program in those Reeds counties. It's seen very impressive outcomes. So we've seen a significant decrease in costs, improved A1Cs, improved rates of BMI assessment, and increased rates of behavioral health utilization. Any questions about Prime? Okay, I'm going to keep going. So the network. So the way that the Colorado Medicaid, so the way the network works in our region is first, all providers have to be enrolled in Colorado Medicaid, and they have to meet state requirements and be a Medicaid provider before they can contract with us to serve in our region. For behavioral health, we are responsible for the contracting and development of that network. So we really want to make sure that we have an adequate network to ensure high quality and timely access to care. For physical health, providers bill, because it's a fee-for-service system, they bill Health First Colorado directly. And the goal is really to have all willing providers as part of that system. Specialty, so primary care also does require a contract with us. They contract to be a PCMP in our network. Specialty and hospital providers under Medicaid do not have to have a contract with Rocky, and they do bill Health First Colorado directly. And then, as I mentioned earlier, dental is an entirely separate contract administered by DentaQuest, and services are billed to DentaQuest. Any questions about our provider networks? Okay. Care coordination. So our goal is really to address whole person care. So our care coordination system includes our call center. So we're actually really working on maximizing all of the people we have and ensuring that they're providing the greatest level of service that they're able. So we are really trying to train and leverage our call center to do some of that like care coordination work. We have internal care coordination staff. There are also integrated community care teams, which are contracted community care teams. We have one, for example, at Mountain Family, and then we have a number of community-based community care teams. We also leverage Whole Health, which is a community health worker program that's affiliated with Mind Springs.
Catherine, we have another.
Christy, you cut out. Well, what is the question?
I think I hit the wrong button. Can you please explain the process for getting a new behavioral health provider in your network?
I was afraid you were going to ask that. So I don't have the nuts and bolts of credentialing at my fingertips. I can definitely connect you with the person that that can help you with that. And if that's something you want to talk about in your community meetings, I can be prepared to talk about that. We have a whole team that does credentialing, and I'm happy to bring that information. I'm sorry I don't have it on the fly.
Kendra, we'll get you some additional information on that. And then someone asked, what is the call center number, please?
Oh my goodness, you guys are asking all the questions. I don't know off the top of my head. I know this off the top of my head, but I don't.
Yeah, we'll follow back up with that.
Christina, are you making a list of things we should send the group after the call?
Yes, I am.
Okay, perfect. I can't take notes because I have the screen up. Okay, sorry, but thank you all for the questions. We'll definitely follow up with those things.
Oh, and one more. This is and how and who decides that we have an adequate behavioral health network? Yeah,
that's a complicated question. I think that's a bigger discussion than we probably can have today. I think you know, we want to make sure that people can get into a behavioral health provider in a very timely manner, and so our biggest metric of whether or not we have an adequate network is whether or not members can get in a timely fashion.
Okay, whether members
but also a big question. Yep.
Okay.
We are committed to having an expanded behavioral health network.
Okay.
So population health. So I really want to talk to you all about population health. So I think it's a term that gets thrown around a lot, but it means a couple of things. So one is when you really look at the whole population, you discover that I think most health plans, and Rocky Mountain included, find that we're not serving whole person needs. We're not necessarily addressing social determinants of health to the extent that we need to. And so it really means figuring out how to have a strategy around physical health, behavioral health, and social determinants of health. You look at the whole population, I think historically health plans and the healthcare system has really focused on those people who have healthcare needs, who have chronic diseases or who are using the healthcare system. But a population health approach means you're not just looking at those higher utilizers, but you're really looking at everyone. And so you're looking at your healthy membership and trying to figure out how you can support them in continuing to be healthy. So that we're really thinking about, you know, how do we do more prevention, more upstream interventions? And then the final piece about a population health approach is that it's really about being data-driven. So really it's about assessing the needs of the population, making sure that the interventions you have or you develop interventions that match the needs of the population, and then evaluating those interventions in a really rigorous cycle where you just continue to evolve your programs based on evidence. So for our year one population health activities, we're sort of focusing on some of the basics. So we really want to think about how all of our touch points with members can be used to drive positive outcomes in the KPIs. So we are focusing on welcome calls, the welcome getting started guide, which is a mailing, our high-risk pregnancy outreach campaign, care coordination and complex care coordination. We have a diabetes program for RAE adults and an asthma program for RAE children. We are working on a hub and spoke model for substance use disorders. I don't think it's come to your region, but it's really around how do we expand the capacity of primary care providers to serve substance use. Social determinants of health screening. So this is something Christina and I work on very closely. We're trying to encourage all of our providers to do social determinants of health screening and referral. We have a criminal justice program that's really about training individuals who are about to be released into the community, and then also providing them care coordination once they're in the community so that they're able to seek the medical services that they require quickly. We want to partner with the Health Communities program. So Healthy Communities is the state's EPSCT, early periodic screening, diagnosis, and treatment vendor. So they're responsible for outreaching kids and families. So we want to really coordinate with them so that the outreach is complementary and that they receive the support they need from us in order to support the individuals they're interacting with. We also want to partner with the Family Resource Centers who do direct family care coordination type activities. They call it family strengthening, but they really support families in achieving their goals. We want to partner with Nurse Family Partnerships, which is a program that serves first-time low-income mothers and really follows them from, prenatal period until 2 months after delivery. And then finally, we're working on a program where we can pay for gym memberships for some Medicaid members based on provider referral. We know that recreation centers can be one way to address social isolation. Obviously, you can address weight management. We know exercise is very important for behavioral health conditions, and so we feel like this is an opportunity for us to try to do something creative to address a number of possible conditions. I'm gonna pause for 1 second before I move on, see if there's any questions. Okay. So the last thing I want to talk to you about, I think this is my last thing, is the Accountable Health Communities model. So before we received the RAE award, actually, we received the Accountable Health Communities model. So the Accountable Health Communities model is a Center for Medicare and Medicaid Innovation initiative that has 3 main components. The first is really bringing together communities, clinical and community partners, to identify gaps in social resources and prioritize those gaps and come up with a plan to address them. Christina is leading the effort in your region, and I'm really excited that she's focusing on supportive housing as a critical gap in your community. The second component of the Accountable Health Communities is that social needs screening, which I alluded to earlier. We are trying to implement social needs screening in practices across Western Colorado. We could use any help we can get in encouraging providers that this is important and it's important for health. And for patients who have 2 or more ER visits and 1 social need, we are providing them with community navigation to assist them in accessing the social resources that they require. So thank you all so much for having me. I just want to leave with, we really need you. So we need you to give us feedback. We often don't have as much insight into what's happening at a community or patient level as you may think. And so please let us know what is and is not working. We also need help communicating with members and communities. We only have a limited set of avenues to communicate, and we really appreciate it when you are able to help share important information and help us think about how we connect with our members in a more effective way. And we really want to partner with you on social determinants of health and key community priorities. So we want to make that a robust partnership. So any other questions?
Can we unmute everybody?
Catherine, this is Nan. Can you hear me? It's just easier.
Yes, I can.
It's easier than typing, sorry.
Oh, you're welcome to talk.
No, thank you so much for this overview. It's answered a lot of questions. Certainly, I have a ton of questions, but one is that I'm hearing from providers that it's very difficult to get reimbursement, and that I heard from HCPF that you all actually have major contacts for providers, consumers, behavioral health, whatever. Is this list that we're looking at, Meg Taylor, Nicole, is that list, or do you all have a contact list that we could use when we hear concerns so we can direct it to the right place?
Yeah, so provider concerns, well, it's sort of complicated because it kind of depends on which system. Any of us can help you figure out the right person. We're all on the community integration team, so we all work under Patrick. We all work on the RAE. Nicole Conkley handles a lot of provider-related questions. If it's payment-related to Prime, Pauline Casey is over Prime. Louise Ren is part of the hospital. She's working on hospital-related activities. But for provider payment, I might start with Nicole. But once again, I'm happy to take your emails and field them to the right person as well.
Oh, sorry. There's another question on chat. The question is, are you looking at developing more after-hours clinics so individuals are not utilizing the ER?
Yeah, so we're really interested in after-hours clinics. We're also really interested in telehealth. So we are trying to explore ways that we can use telehealth platforms so that members can get medical care without even leaving their homes during after hours. So that's one strategy we're exploring.
This is Joanne in Summit County. I had a question as to how public health fits into all of this. I know we were just talking about they do a lot of work on social determinants, and I know they're a partner, but do you meet with them separately, or would they be at the table when you come to meet with us, or maybe I'm just missing something?
So I'm not sure. Are you speaking about these county meetings we're facilitating in the near future, or are you speaking just broadly?
Both.
Okay. So for the county meetings, I would hope public health is included. Christina, are we including public health? Yeah, okay.
Yeah,
I think we're including them.
Definitely included. And Joanne, you are welcome to invite anyone you would like to invite, because I don't have as an extensive contact list in Summit. So please.
Okay, good. That's what I was wondering.
People, and you can send me emails, whatever you'd like to do. And that's the same for everyone in each of the counties. And I just wanted to mention the first actual county meeting is coming up on Monday, and that's the Pitkin County one, and that's going to be from 11 until 1 p.m. And so the other meetings are going to happen. The Eagle meeting is happening on November 7th from 11:30 to 1:30. Summit is November 15th from 10 to noon, and Garfield is December 12th from 10:30 to 12:30. And I will send out a list of all this, so you can. Some of you are regional and some of you are one county. You're welcome to attend, the ones that make sense for you. We'll be doing a final wrap up at the January West Mountain Quarterly meeting, where we'll come up with sort of our RAE Region 12 overall goals.
Okay. And we would love to have public health at our November 2nd meeting. I just kind of keep plugging it. It would be great to have a strong public health presence. I do, Jeff Kerr has a group, bringing together some Western Colorado public health directors, and I have been invited to join that group a few times. I'm really motivated to figure out how we can align with public health, because I do know that they're doing some of this work already, and we want to obviously support what they're doing rather than recreating the wheel.
What other questions do you guys have, and that we can answer, that Catherine could answer, or we can get back to if we don't have the answer?
And if you think of things you want discussed in your county meetings, please let me know. I know a lot of things off the top of my head, but not all the things. So I'd love to have a heads up.
Awesome.
Do you have, for the county meeting, which is on Monday, I don't think I saw, or maybe I saw it and I didn't get it, just an org chart of the RAE, reunion, the RICO, the peer coordinators, no, is that too much?
I just asked someone for that. I literally, before this meeting, I asked someone, I said, do you have this? I want to show a picture. I don't have that. So I'll see if I can come up with something by Monday, but I might not be able to. I'm out tomorrow, so I'm sorry. I might not be able to come up with something, but it's pretty complicated. We could draw it on the board.
Yeah, it's just funny because a lot of the terms don't say what it is, right? So for consumers, it's like, we don't know what you're talking about, but we'll get past that. We have a good group coming on Monday. I think the other question that I have is, I've asked a couple of times, how would we get agendas or minutes for reunion? And do they ever entertain public comment? Are there opportunities for community to influence the decisions that are being made on our behalf?
Yeah, so that's the goal of the PIAC. And that's the goal of the community governance process. And that's why we have that directors committee that has both reunion and external partners on it. because we don't want it to be an insular group making decisions. Also, I just have to say, not that many. I wouldn't worry that there's a plethora of decisions that have been made. I think we're all sort of, fumbling through the operational logistics of, many of these new, the 6 visits is a new. I actually didn't mention the 6 visits, but now you can seek 6 behavioral health visits. Man, that was a big omission in this slide deck. So one of the big changes under the RAE is that patients can have up to 6 behavioral health visits in a primary care office. So it doesn't have to be necessarily with a license, it has to be a licensed behavioral health provider, but it doesn't have to be within the behavioral health contracted system. So that's actually a pretty big opening of access. So I'm sorry I didn't mention that. But I think mostly we're working through a lot of operational issues so far.
Thank you. Great. All right, if there's no more questions, speak now or hold your peace. But I just want to say thank you so much, Catherine, for taking the time and for taking the opportunity to explain this. And I'm sure there will be follow-up questions, and I can pass those on. And we will follow up with some of the questions that were asked that we didn't have the exact answer. And all of you are welcome to send questions my way too, and I can try to forward them to the right person. So happy to do that.
I forgot, Christina, one of our deliverables to HCPF to identify how many and who participate in the webinar and view the webinar afterwards. So I hope you got all the names.
I do. Unfortunately, some people only come up with their phone number, and that's the challenge. So if they didn't is anybody on the call that did not get introduced at some point with anyone new who joined right after, because we did quick round of introductions with Catherine. Can you let me know if you joined and who you are?
This is Elaine Gerson from Aspen Valley Hospital. I joined late, sorry.
Okay. Hi, Elaine. Great. Thanks.
Hi.
Hi, Elaine.
Hi.
Who else is on the call that did not get introduced? I see possibly Jolene and Chris Montera. Is that correct? They might not be accessing their Ada. I think you're on there. So anyone else? There's still some that just show one name, or there's one that says Wolf. So I don't know what that one is. And what you could do is, if you could just type in the chat your name and that you came to the webinar, that would be awesome. So if you could just grab the chat box and just type your name, that would be a great way to record who all is here. Awesome. Thank you for doing that. And that'll make sure we can capture that information to meet the needs of the grant, and also to follow up and,
Can I ask, and I don't know, Nan and Christina, if you want to follow up after this, but I'd love guidance about what you want in the county meeting. So if anyone, either in this group or if Nan and Christina, you want to give me some direction, I'd like that.
Okay. Why don't, Nan, does it work to have a quick call right after?
Sure.
Okay.
we did a survey, and we've had 18 responses so far, and the survey is open through tomorrow. But that survey we're using as sort of a grounding of the issues and themes. So we actually have an idea of the concerns of the people who are coming to the meeting.
Oh, that's great.
Yeah.
Thank you.
Yeah, thank you. Thanks, Christina.
Awesome. Thank you guys for letting me know who's here, just so I can capture that. That's really helpful. Very cool.
Right.
Any other questions, or we'll wrap up in just a moment.
I just want to say, I think a webinar is a great way to get information throughout the region. And so when you talk about communication, Catherine, I think there's just a great opportunity. I have found that ACHM meetings are time consuming and distant, hard to participate in, but little brief focus points or focus areas could be super helpful.
That's good feedback. Thank you.
Definitely agree. And I think what's nice is that when it's hard to have an in-person meeting and an online meeting. So when it's just everybody's online or everybody's in person, it seems to work a lot better.
Yeah, I agree. Thank you.
Great. Well, I think we'll wrap up. So thank you guys for joining, and follow up if you have other questions.
Thank you, Christina.
Yeah.
Thank you.
Thank you.
Bye-bye. Have a great day, everyone.
Thank you.
Thank you.
Should I call in on another number or? Whoa-y, wow.
Or we could just stay. Well, I think Catherine got off. So why don't we just
You want to call my cell or something? Do you have contact capability?
Yeah, I can do that. What's your cell number?
618-9064.
All right.
Hey, congratulations. I hope it recorded.
I do too. It looks like it did, because we are going to stop the recording.
Oh, okay. Good.